PTOT, speech therapy department here at Lincoln, how big orthopedics was. Orthopedics are big. But I'm not interested in orthopedic shoulder flexion. I'm interested in taking the neurology that's limiting that flexion before we actually look at the orthopedic joint. Does that make sense? So I'm going to create a neurological nightmare for you. I'm going to take some toweling and I'm going to put it under his left side. Okay? I think this will be enough. Simple toweling, and I'm going to put it right there. That's called left rib cage external rotation. Okay? Now he's in, let me back off. With the toweling there, I moved his trunk to the what? Right. He will have full internal rotation on the right arm yet. He would have full internal rotation on the left arm in that position. He would have full shoulder flexion if I stop right there. If I stop there. But he can't go all the way down, can he? So I created flexion limitation. He would have full horizontal abduction on the right side. Everybody with me? What did I do with that toweling? What did I do with the toweling? Did I turn his spine to the right or the left with the toweling? Let's think about this. I took and I lifted his rib cage up on the left side. I turned his spine to which direction as I did that? To the right. I oriented his spine to the right. That's a better word. I meant to say oriented. So we'll strike the word turn. I oriented his spine to the right. If I oriented his spine to the right, do you remember the picture of the brachial chain? Do you remember the picture of the brachial chain where at the right brachium, the right thorax was moving back? Do you remember that earlier this morning? And the left one was moving which way? Forward. If the left one's moving forward, these ribs are now what? Externally rotated. So I'm going to slide him over. He's going to slide on over. Keep going. Don't fall, whatever you do. And I'm going to put this back only under the left side. And I'm going to come over here, and he's going to have full horizontal abduction. He's going to slide back over to the middle with this towel under him. And I'm going to come over here and show you a nightmare, which is outlined in your handout under illustrations, which was what page? Again, one more time. The diagram of the scapula with IR.
Oh, well,
Scoot that way.
in your regular manual, page 45 goes through scapular and humerus, but on page appendix 53, it goes through scapular rotation.
That's what I meant, yeah. So stay for. So now, his IR should be significantly limited on the right side. For all the reasons Jen raised. Let's see if that's true. That's all he has. Jonathan, would you want me to go any more than that?
Probably not.
Would you want me to go there?
Maybe.
And now you understand my concerns. I just put a little toweling under his left side. So Tessa, do you understand? How are you doing today? How's it going today? How are you doing? How are you doing today? Are you using your left diaphragm? Are you getting air in your right chest wall? How are you doing today? Do you feel your left posterior mediastinum? Tyler, how are you doing today? Do you feel your spine? Is it turned to the right without you leaving the butt on the left? Tessa, how are you walking okay today? How's your heel pain? Has it gone away? How's that plantar fasciitis, by the way? Hey, when was the last time you blew up a balloon? Can you do it? Do you guys understand what I'm saying? He just lost 60% of internal rotation with toweling on the left side. It's not real good, is it? That's a concern. And see, when I read research, the first question I want to know is how are the patients doing? The selection of the population you used for that study, did you make sure they were all doing just fine? They all could do one thing? Breathe. That's all I want to see. Research when people can do what? Breathe. Because if they can't do breathing, what kind of research project do you really have? He's going to flip around, and I'm going to show you his limitation of horizontal abduction on the left side. He had full horizontal abduction on this side. He's going to flip around. I'm going to take that little bit of toweling, and I'm going to put it on the left side, and we're going to see what he has for horizontal abduction. Oh, no, you know what? Yes, come on over. Go back to your left. Now, that's the demo of a nightmare. Now, all I'm going to do is I'm going to keep the toweling there. Here's what I'm going to ask him to do. Go back to the middle. Right now, when I take the toweling away, it's not a magician show, take the toweling away, he has full horizontal abduction on the left side. Now I'm going to use air. I'm going to take and I'm going to displace his rib cage. I'm going to come over here on the right side, and I'm going to create a neurological nightmare. I'm going to give him strong ZOA on the right side. You guys with me? I'm just going to let him breathe 5, 6, 7 times with air only going on which side. And I'm going to show you how to have the same results. So you can do it with a towel, or we can do it with air. And tests I could probably do with his cranium, his pelvic floor, his inlet, his outlet, his feet, and his knees. Do you follow me? It just depends on how you want to do this today. You happen to be in a class that talks about airflow. I'm now going to take away his left posterior mediastinum rib. That's all I'm going to do. He's going to take a deep breath of air in. He's going to blow out all the air. And I'm going to hold him here. Did a really good job getting a good night's sleep. And Brianna, I'm just going to try to see if he can get that air in over there. There he goes. Every breath he takes, he's going down a little further. Can you feel it, Jonathan? Mm-hmm. Little further. This is what he looks like at 3 o'clock in the afternoon on the university campus, running around with students. Maybe taking a class or two, I don't even know.
Yeah.
This is what he's feeling, right here. Airflow only going which side, everybody? This is called hemithoracic function. Jonathan, you're almost there. You just got there. You just got there, my friend, because you are moving your right rib cage at all. Put your left hand on your right rib cage. Your left hand on your right rib cage. And keep it there.
Oh, I see what you're doing.
And now breathe. Did you have to really move that right rib cage? Okay, so here we go. I won't flip him around. He had, before we did this, he had full internal rotation on the side. Whoa, would you want me to go any more than that?
No.
It's kind of weird, isn't it?
Yeah.
Would you want me to go any more than that?
No.
Well, wait a minute, the towels are over there. How did that happen? How did that happen? Wait a minute, let's see if this is true. Come on over here. This is where you were yesterday, John. Come on over here. Jonathan, the towel's over there. Whoa. Dang it. Jonathan.
What'd you do to me?
What happened, buddy? Whoa. That's not good. Now, let me check this flexion business, okay? Let me see if this is true. How can that be? Wait a minute. Look. Full flexion on this side. Whoa. You had this a few minutes. What happened? Do you want me to push, Jonathan? No.
Probably not.
Towels are over there. I'd be shaking if I were you guys. That was a nightmare. And for people who are seasoned, that was a big nightmare. Now you understand, Tessa, why I'm glad you're here. Because you're a PA. help a physical therapist understand what that orthopedic doctor needs to do before they do surgery. And maybe even after the surgery that was needed. That makes sense to everybody? Because I can't stand it, I'm going to do a new technique on him called the sternal technique right now. I'll show you where it's in your manual. We'll leave it right here, and then we'll reposition him. And then we can get into this treatment program after I talk to you about what happened to his neck. But was that demonstration helpful, Mike? Did that help you guys? Was that helpful? Joy, did you get something from that? Now, apply that to every single patient that walks or client you work with, and I think you got a pretty good objective of what you need to work on. Airflow has got to go onto the left posterior mediastinum. I just took it away. He took it away. He did a really good job taking it away as he laid there and only used his right diaphragm to stabilize himself as he got air into which chest wall? The left. And as he laid there, Jonathan, please tell everybody if this is true. As you laid there, it was easier and easier to what? Breathe. And as it got easier and easier to breathe, he was going into his old pattern, Tessa, which God gave him. So when he's taking a test or working with an belligerent student or an athlete, it gives him a little stress. Or Mike. I'm joking. You got a little stress in your life, the first thing he's going to do is go directly to that behavior. So I want people to learn how to manage stress with a new behavior. I want the zone of apposition to be realized on which side? The left side. And then management of things probably is going to be pretty cool. Will you feel empowered after you get your left posterior mediastinum? Yes. But you're going to be cocky because that empowerment's going to go away pretty quickly because you're not strong in that new position. And a few hours later, you're going to say, whoa, what happened? I was pretty strong and now I'm not. Because what muscles got to be tested? I'm looking because you're about the sweetest, honest person in the room. You don't have any, you're out there, you're a PA. How can I get my patients better? What muscle on his left side, don't say abs, don't say glutes, don't say hamstrings, because that's what everybody in this room is going to say. What muscles got to get stronger when he has that left posterior mediastinum in place? On which side? Congratulations! The left hemidiaphragm has got to get what? And it's not going to happen in an hour from now. It's going to take months for that left hemidiaphragm to get stronger. Now you have me, because you told me after you get rotation and after you empower the left posterior mediastinum, I'm going to put a person on a program that's going to get the left hemidiaphragm what? For being you. How are you? How are you breathing? And we complete the course. Done. Got to put him on a program that's going to get his left diaphragm what? Stronger. Which means he has to keep his zone of apposition, which means he's got to keep his trunk rotation, which means he's got to get air into the posterior mediastinum of his left side. And that is entirely the objective of every single technique, non-manual technique you have in your handout. That help? Just put closure to that. She's going to read a technique called the sternal technique. And what page is that on?
36.
I'm going to dampen this towel. You go ahead and read. Jonathan, we'll leave you right there. You doing okay, buddy?
Yeah.
Okay, she's going to read this. I know this is hard when you're laying down to listen to, but are you following all this? You doing okay? I'm going to warm this towel. She's going to read this, and we'll tell you how to do the sternal technique. Sternal technique, Jen, go ahead and read.
Patient is positioned supine with knees supported in a 90-90 position. The operator at the head of the patient with one hand or both hands over the lateral border of the sternum and triangular sterni muscle. Inhalation. Upon air in, the patient flattens back and with pelvis posteriorly tilted draws in air into upper lobes without using neck. Operator guides air in by supinating the left arm and tipping the left inferior lateral border down. On exhalation, upon